Okay, great. Okay, so so I'm going to talk for the next 30 minutes or so, maybe a bit shorter, maybe a bit longer, but there'll be time for some questions. And I'm a neurology consultant based in Birmingham, and I've had a specialist interest in headache now for about 10 years. So without further ado, I'm going to talk about migraine, acute and preventative treatments. These are my disclosures. So the plan of events will be that first of all, I'll talk about acute management of migraine, then we'll talk about migraine prevention, and then we'll spend a few minutes talking about the new monoclonal antibodies against CGRP. Okay, so when it comes to acute management of migraine, the key thing is to use medication in combination. The old style of thinking was that we used to escalate painkillers. So you may start off with paracetamol, and then if that didn't help, you then add in some ibuprofen, and if that didn't help, some people even took opiates. But it's now recognized that actually taking medication in combination early on during the attack is the most effective way to kill a migraine. And we suggest that you take a combination of non-steroidal anti-inflammatory drugs or paracetamol if they're not tolerated, with a triptan, with an antiemetic drug. An antiemetic drug is an anti-sickness drug. And even if you're not feeling sick, the antiemetic drugs can be useful because they can help with so-called gastroparesis, which is slowing down of the gut. And this can actually help get rid of the migraine. So regarding the non-steroidal anti-inflammatory drugs, and again, some people just don't tolerate these, you can see there that there's a variety that you can take. You can take aspirin, ibuprofen, naproxen, diclofenac, or tolfenamac, or you can take paracetamol. And the other thing that you'll notice with these non-steroidal anti-inflammatory drugs is that the doses at the side are probably slightly higher than you see on the packet. So if you buy ibuprofen, each tablet's 200 milligrams, but we recommend a slightly higher dose. Okay, so I'm going to talk more about the triptans, because those are the painkillers really which have thus far revolutionized the way that we manage acute pain in migraine. And these drugs antagonize these drugs work on a particular receptor in the brain, and they cause vasoconstriction of blood vessels. And for this reason, they're contraindicated in certain conditions where patients have underlying vascular problems. So patients with uncontrolled hypertension, cardiovascular disease, or stroke shouldn't take triptans. And if you've been using triptans for a long time, and then you develop ischemic heart disease or angina, there's a good chance that your GP will unfortunately have to stop your triptans. There are a few other occasions when you can't use triptans. Historically, people used to use ergotamine to control pain. It's no longer available, but if some people try and get it by other means, and you can't combine these with triptans, and also you can't use triptans with monoamine oxidase inhibitors, which is sometimes used to treat Parkinson's disease. Okay, so triptans, as I said, they're specialized painkillers specifically for migraine and also actually cluster headache. But if you were to bang your knee or bang your back, and if you took a triptan, it wouldn't make a jot of difference. So that it's much more to do with migraine. And they're generally well tolerated, although some people feel a bit weird when they first have a triptan, and they may feel quite flushed, they may feel slightly dizzy, and about 7% of patients report chest discomfort. But this doesn't mean that you're having a heart attack. Are triptans safe in pregnancy and breastfeeding? The answer to that is, well, yes, probably they are. Certainly, if patients have been using triptans for a long time and they've tolerated them extremely well, and they seem to be working really well, and they have very disabling migraines, then we would suggest that they use them in pregnancy and breastfeeding if there's no alternative. But it's something that we probably wouldn't start de novo in someone who's pregnant, who's never used them before. Okay, so these are just questions that my patients often ask me. So when should I take a triptan? The key thing is with triptans, we recommend that you take them in the early phase of the headache. So as soon as you feel as though a bad migraine is coming on and the pain starts, that's when you should take your triptan. There's no evidence at all that taking a triptan during the aura phase, which 30% of you will develop, there's no evidence that taking the triptan in the aura phase is beneficial. And in fact, there's no medication at all that you can take in the aura phase to get rid of the aura, which is really frustrating if you're someone who just gets visual aura in the absence of headache. There's nothing you can take acutely to get rid of that aura. Okay, so how often can you take triptans? The key thing is not to go over the recommended daily dose. And often triptans come in 2 doses. There's a low dose and a higher dose. And the higher dose is usually double the low dose. And providing you don't take more than the full highest dose in a given day, then you shouldn't run into any problems. The key thing also is don't combine triptans. So if your GP's prescribed you some triptans, say, for example, sumatriptan, and for whatever reason, later on you've been given some frovatriptan, don't take both triptans in the same day, because again, that can cause problems, especially in terms of ischemic heart disease. How often should you take triptans? Well, on average, we say don't take triptans on more than 2 days in a given week. This applies to if you're taking triptans over prolonged periods of time, because if you do, you're very likely to develop what we call medication overuse, and I'll touch on that later. But if you're someone who just gets, for example, 7 days of bad migraine around your menstrual cycle, then it's okay to take triptans on a daily basis, providing you're not taking them for the rest of the month. Okay, so these are some more questions. So are triptans safe to take with migraine aura? The general rule is that providing you don't have hemiplegic migraine, which means weakness down one side of the body, then they are safe. That said, we know that triptans are actually very effective in patients with hemiplegic migraine, but because there's a theoretical risk of increased stroke, they're not recommended. But it's always a case of weighing up the risks and the benefits. And I certainly know some patients who have hemiplegic migraine who take triptans, and it's a lifesaver for them. So what do we do if the triptans stop working? Well, as I said, they usually come in 2 doses, a low dose and a high dose. If the lower dose isn't working, then you can increase the dose. Also, triptans can be given in different routes, so orally, nasally, or as injections. And if one route doesn't work, then it's worth trying a different route. We've already said that taking triptans in combination with non-steroidal anti-inflammatory drugs or paracetamol can help. And the general rule is that if you've taken a particular triptan on 3 occasions and it's not working, then the GP can then try you on another triptan. Some patients don't tolerate the first triptan that they've been prescribed, and they're really worried that if they're prescribed another triptan, they're going to have a similar adverse side effect. But that's not always the case. So it's worth trying a different triptan, even if the first one wasn't tolerated. Okay, so there's 7 different triptans, and I've just put them here in alphabetical order, and they can be given as a tablet, so orally, nasally as a nasal spray, or in the case of sumatriptan, this can be given as a subcutaneous injection. And the type of triptan that we use really depends on the type of headache that you have. In many cases, the GP will start you off on oral sumatriptan, because this is the cheapest triptan. It's the one that was first released, and it seems like a sensible starting point. And majority of patients will start on oral sumatriptan. Okay, so if you're someone that gets very prominent nausea and vomiting, then it makes sense not to have a tablet, because you'll be vomiting and you won't be able to keep that particular triptan down, and therefore you're unlikely to be able to abort the attack. So in this case, if there's prominent nausea and vomiting, it's good to take a nasal spray, so sumatriptan nasal spray, or you can take zolmitriptan nasal spray. And if that doesn't work, some people benefit from the subcut injection. And of course, after that, you can take the antiemetic, And there's one antiemetic, buccal prochlorperazine, which you can take, and it's just a tablet that you put in your mouth, and it sort of just dissolves in your mouth. Unfortunately, there aren't any preparations now that you can take per rectally, and they used to be able to take them, but now that they're not available. Okay, so some people get very rapidly progressive migraines. And what do we mean by that? Well, it means that, as you know, within a few minutes of the headache starting, they're completely destabilized and they're, you know, almost bedbound. And in this case, you need to get the drugs into the system as quickly as possible. And all of these different formulations of triptans get into the bloodstream at different rates, and they hang around for different rates. And the ones that I've highlighted in yellow here are the ones which we know get into the bloodstream more quickly. Some of you will be familiar with rizatriptan Maxalt melt, and these are sort of wafers, and these get into the bloodstream very quickly, and therefore they're more useful in people who get migraines which rapidly progress. And of course, the nasal sprays and the injector pens are very useful in this situation as well. Some patients wake up in the morning with severe migraine, and the sumatriptan injector pens are very useful in that situation. The problem is with injector pens is they're quite expensive, and some GPs don't like prescribing them. Okay, so some people get migraines which come in sort of clusters over a few days, and that's not to be confused with cluster headache, but you may get a run of 2 or 3 migraine days in a row, especially some women around the time of their period. And if this is the case, it's better to use the triptans which are longer acting. So in other words, these triptans stay in the blood for longer, and therefore their effects are more, they work for longer. And these include almatriptan, frovatriptan, and naratriptan. And frovatriptan is the one that lingers around in the blood the longest. And these, again, if these are taken in combination with an NSAID or paracetamol, then that's good for patients who are getting headaches which linger. Okay, so I just wanted to touch on medication overuse, because this is a big problem, and it's something that GPs are gradually becoming more aware of, and patients are gradually becoming more aware of. But it's a crazy situation, and it seems very paradoxical, but the more painkillers you take if you have migraine, then the worse your headaches can become over time. And we know that if you take painkillers of any description on more than about 15 days in a given month for more than 3 months, then you're likely to develop what we call medication overuse headache. And medication overuse headache mimics the headache which you're treating, and this is particularly common in people with migraine. So, for example, some patients will take triptans every day, and they'll be very dependent on those triptans, but we know that they're probably contributing to their headaches, and it also makes treatment with the oral preventatives much more difficult. The difficulty is getting off these medications, because you get to the situation where you're not addicted to them, but you're dependent on them to function, and you know that if you don't take your triptan, then you'll end up in bed, and it becomes a vicious cycle of taking lots of medications. The simple analgesics and non-steroidals can be taken up to 15 days in a given month, but the triptans and the opiates, so opiates we mean things like codeine and tramadol, they can only be taken on 10 days in a given month. And if you're taking a variety of different painkillers, so paracetamol, non-steroidals, and triptans at different times in the month, then we recommend that you don't take them on more than 10 days in a given month. Or one way to look at it is only take them on 2 days in a given week. And this can be difficult, but we know that if someone's got good going medication overuse headache, then if they stop taking their painkillers, then after 8 weeks, probably around 2/3 of them will be significantly better. But achieving that can be very, very difficult. Okay, before I move on to talking about the oral preventatives, it's worth just touching on lifestyle, because lifestyle is super important when it comes to migraine, especially with adolescents and young adults. this is just because, you know, life is different when you're that age, and you tend to not look after yourself as well. But I always, it's the things that our parents nag us about. So breakfast, regular meals, keep well hydrated, avoid too much caffeine, don't drink energy drinks even if you're tired, avoid sleep deprivation, and equally having a regular sleep wake cycle is important. So lying in at the weekends, having naps during the day is a no-no when it comes to migraines. And then of course some people discover various triggers. My feeling about triggers is unless they slap you in the face, then it's probably not a trigger, and I tend not to advise people to avoid, you know, dairy, avoid citrus, avoid eggs, you know, low carb diets, because life becomes pretty miserable if you start avoiding all those things. So the other thing, I put this picture at the bottom right hand side of the screen. Environmental triggers are quite important with migraine, especially sort of very symmetrical, contrasty images, and these are quite common in sort of modern architecture and carpets and wallpapers and things, and these can trigger migraines. So so especially when people are at work, you have to be careful about having desks which have sort of glass desks, and where there's lots of glare and, you know, odd fluorescent lighting. This can all trigger migraine. Okay, so why do we use migraine preventatives? Well, we use them to reduce the frequency, severity of headaches, and also to reduce analgesic use. When do we use them? Well, the general rule is that if someone's getting more than 4 days of migraine a month, which equates to one headache a week, then the risk benefit is in favor of taking the preventative. Don't forget that all of these preventatives, you know, they have side effects, and if you have to balance the side effects with the benefits of reducing the headaches. Okay, so which one should I take? And I'm going to go through them all in more detail later. Essentially, often as a headache doctor, I'm guided by a patient's preference and also what other things they have. So example, if you're an asthmatic, then of course you can't take beta blockers because you may cause an asthma attack. If you've had kidney stones, then you wouldn't be allowed to take topiramate, because we know topiramate can cause kidney stones. So you're often guided by what else that patient's what else is going on with that patient. So the general rule also with preventatives is that you must start off at a very low dose, and this must be slowly escalated over several weeks till you get to the dose within the therapeutic range. And this can be really frustrating because obviously if you have bad migraines, you want to have something that works very quickly, but you need to realize that sometimes it can take you 8 weeks to get to the right dose, and then you have to continue that for another 2 or 3 months before completely dismissing it and moving on to the next drug. The reason that it's so important to do that is because if you start and stop medication quickly, then before long you've gone through a whole host of oral preventatives, and then you know, there are no other options. The general rule is that we continue oral preventatives for between 9 and 12 months, and then if someone's headaches have improved significantly, we try and get them off those drugs, see how they are, and if necessary, restart them at a later date. The key thing with migraine, I think, one is expectations. There's no cure for migraine, and it bites you in different ways in different stages of your life. The other thing is you have to look at life in 3 or 4 month blocks. So it's super frustrating, but often medication takes a while to work. Okay, so these are the 4 different sort of general classes of migraine preventatives. We have the anticonvulsants, the antidepressants, the antihypertensives, and then other, I put at the bottom. Now the ones in red are the ones that are recommended by NICE, so that's the National Institute of Clinical Excellence. And some of you may be aware of this institution, but basically the recommendations are usually on clinical and cost effectiveness. So if a drug is very, very expensive, then they may not recommend it, even if it's a very good drug. And often their evidence is based on randomized controlled trials, and lots of these drugs have never been in randomized controlled trials, and therefore they can't be recommended. So, so first line, NICE recommends topiramate or a beta blocker, and second line riboflavin. But generally speaking, this probably isn't the order that most headache doctors would start preventatives. Okay, so the other thing to be aware of is that some migraine preventatives cause low mood and depression, and this is especially the case with topiramate and flunarizine, and can occur also with beta blockers. Weight gain is a problem for some people, and we know that certain drugs can contribute towards that. Sodium valproate is quite a dirty drug. It's historically, it was used very much in migraine, but there's lots of problems. It can't be used in pregnancy. It causes weight gain and liver problems, and we tend to use it much less now. Most of the antidepressants, unfortunately, cause weight gain. Beta blockers can cause weight gain, and pazotafen again can cause weight gain. Okay, and there are other side effects that you need to be aware of as well. So topiramate can cause kidney stones, as well as low mood, must be avoided in pregnancy. Beta blockers, we've already talked about asthma, and candesartan can cause a dry cough. And because of the whole COVID epidemic, people are reluctant to start that. So, so just from my own practice, this is my thinking in terms of when I prescribe migraine preventatives. We're just talking about the oral preventatives now. I sort of categorize them as soft options, and these are the things that you can buy over the counter, like magnesium, riboflavin, coenzyme Q10. And we know that there's some evidence that these work. They're very well tolerated, but they may not be useful if you're having severe regular attacks. And then at the other end of the spectrum, we have drugs like topiramate, which is a harder option. And we know this is probably the best oral migraine preventative, but a third of patients don't tolerate it. And then you have everything else in the middle. And depending on how severe the attacks are and how often they occur, that's what sort of guides me in terms of what medication to start with. Usually, I'll start with an amitriptyline or a beta blocker. If someone's having severe attacks, may go for topiramate. If it's someone who's a teenager and they're not too bothersome, we may try them on some coenzyme Q10. So you have to be guided by what else is going on in that patient's life and also what they want. Okay, so acupuncture is recommended by NICE, second line. It is useful. It's not for everyone, but it certainly can be useful in some patients that have got difficult migraine, and it's something that can always be added on as an extra, even if you're on oral preventatives. Often though, you have to pay for this yourself, and it's not available on the NHS. Some of you may be aware that precision tinted lenses can be very useful for patients with migraine who get visual strain. And if this is something you want to try, if you're very sensitive to light and get visual strain, then you need to go to an optician and have your eyes specially tested. I wouldn't recommend buying any glasses off Amazon or just off the shelf, because the different colors are specific for different types of people. Okay, so chronic migraine can be defined in patients that get more than 15 days of headache a month for more than 3 months, of which at least 8 days of a migrainous. And this is a difficult problem. And out of the oral preventatives, there's only really data for topiramate being effective. So if people have chronic migraine, they often quickly move through the different oral preventatives and end up on something else. And but Botox or botulinum toxin is something that's been around for about 20 years, although it's only really been used in the headache world for the last 10 years or so. And this is effective in up to 70 to 80% of people. And it involves 31 injections, 1 between the eyes, and then 15 each side of the head, shoulders, and neck and scalp. And you have these injections every 3 months, and generally speaking, it's very well tolerated. Some of you may have heard of occipital nerve blocks, and typically we use lidocaine with and without a steroid for this. And again, this can be very useful for people with chronic migraine, especially if they have so-called cervicogenic headache as well. So lots of the symptoms are coming from the neck. I found this very useful in my patients. Okay, some of you may be aware that there are various electronic gadgets that you can use for migraine. Unfortunately, these aren't available on the NHS, but you can get them privately. The Wakerley device is a so-called supraorbital nerve stimulator, a little bit like a TENS machine. And you put this on your forehead, and you use this every day and also during attacks. And that can be bought from the company directly. And then the other ones you have to sort of rent, the e-Neura and the Gammacore. The e-Neura is a transcranial magnet which you put over the back of your head, and that can be useful in patients with prominent aura. And the Gammacore device is a vagal nerve stimulator, and that can be useful in some patients with a difficult chronic migraine, but again, it's not available on the NHS for migraine. Okay, so I'm going to spend the last 5 minutes talking about these new drugs. These are antibodies against calcitonin gene-related peptide, and this is a neuropeptide which is essentially very important in the pain system in migraine. And we know that during migraine attacks, CGRP is released into the blood. And we know that if you give someone an injection of CGRP, then it will induce a headache, which is similar to migraine. So therefore, it makes sense that if you block this molecule, or if you block the receptor that this molecule normally latches onto, then there's a good chance that you can reduce migraines. And this is certainly the case. So there are 4 different CGRP monoclonal antibodies out there. The first 3, so Aimovig, Adjuvig, and Emgality, have all been approved by NICE, and they are available on the NHS, or will be available in the months and years to come. I say years because sometimes it's difficult to prescribe these drugs because the hospitals don't have the infrastructure. The last one is currently being assessed by NICE, and essentially they're all indicated for chronic migraine, but Aimovig and Emgality can also be used in episodic migraine. So patients that have had 4 migraine days a month that have failed on at least 3 preventatives can have Aimovig or Emgality. And in terms of the dosing, the first 3 are given as subcutaneous injections. So you get an injector pen, which is delivered to your house. And it's a bit like using an EpiPen. You just take the lid off, wipe your leg, put it on your leg, press the button, and it gives you an injection. And then you throw it in the bin. So they're very, very simple to use. And in the case of Aimovig, you have that once a month. Adjuvig, you have once a month or once every 3 months, and Emgality, you have once a month. The last one you actually have intravenously, so that's something that people will actually have to come into hospital for, but that hasn't been approved by NICE yet. So in terms of who's allowed to have the CGRP monoclonal antibodies, it's if you have chronic migraine and you failed on at least 3 preventatives, then you'd be allowed to have it. And if you have episodic migraine, at least 4 days of headache a month, and you failed 3 preventatives, then you'd be allowed to have it. Excuse me, when should it be stopped? Well, you're assessed after 12 weeks, so after 3 months, three lots of injections, you'll have a call. And if things haven't improved by at least 30% if you have chronic migraine, or at least by 50% if you have episodic migraine, then it would be withdrawn. And generally speaking, after someone's been in remission for a year, then we would try and get them off it as well. Again, it can't be used if you have uncontrolled hypertension, any significant cardiovascular disease or stroke. You can't have it if you're pregnant or breastfeeding, and there's no data really for patients over the age of 65. So you can use them, but there is obviously an increased risk. And because these drugs were introduced very, very quickly, it's not to say that they won't be pulled in the future, because it may be the case that CGRP, by blocking CGRP in the longer term, increases your risk of stroke or heart attack. We don't know. So it could be pulled in the future. We just don't know. However, they're very well tolerated, much more than the oral preventatives, and less than 5% of patients complain of any side effects. And side effects usually are local injection site problems, so rash or reddening of the area where it's injected, and some patients also get constipation. Okay, well, thank you very much for listening. For those of you that use Twitter and tweet, then by all means tweet something. This is fairly new to me, but I'm glad. I'll be happy to hear from you. Thank you very much. If there's any questions at all.
Lovely, thank you, Ben. There have been lots of questions coming in, and that was a great talk. There was lots of really good information. So I will get started on the questions, if that's okay with you. So the first one is around managing around acute pain management for someone who's allergic to non-steroidal anti-inflammatory drugs where paracetamol isn't effective.
Right. So this is a question which is often asked. So if you can't tolerate or you're allergic to non-steroidal anti-inflammatory drugs, and paracetamol isn't effective, then I certainly suggest using a triptan. If the headaches are infrequent, then we'd be happy for you to use an opiate. But you have to be, it's a bit of a slippery slope with opiates because you can get physiological and psychological addiction to them. So if you're taking them regularly, then you can run into problems. But if the attacks are infrequent, then I'd be happy for you to have a triptan or an opiate.
Lovely, thank you very much. And the next question was that there have been some studies linking amitriptyline to dementia. Do you know anything about the studies, and do you consider it safe for use? Also, is it safe to take alongside the triptan?
So amitriptyline we use all the time. I'm not aware of any hard evidence that is associated with dementia. It's something that sometimes people ask me about, and I don't think we've got enough evidence to link the two at present. In terms of with triptans, yes, you can take them with triptans.
Lovely, thank you. And can you talk a bit more about triptans and hemiplegic migraine, please?
So yeah, this is a really difficult one because they're not licensed for patients with hemiplegic migraine. And what do we mean by hemiplegic migraine? Well, we mean where there's weakness down one side of the body. Okay, so it's different to numbness. It's weakness down one side of the body. And if you hit the internet, you'll see that there are several studies which show that triptans can actually be very useful in patients with hemiplegic migraine. But because they're not licensed, there is a reluctance to prescribe them because there is a theoretical risk of an increased risk of stroke. And this is something that is important because I have had patients that have had migraines which have turned into strokes. So therefore, we have to be a little bit careful. I think it's like everything else, you have to use your common sense. If you've got no other cardiovascular symptoms and you're younger than 65 and you've been using them for a while, then I would be happy for that person to continue with them. If you have significant cardiovascular symptoms like high blood pressure, high cholesterol, diabetes, and you're at risk, you're at a greater risk of having stroke, and you're older, then it tips the balance in the other direction, and I'd be much less likely to prescribe them.
Lovely. And sticking with triptans, someone wanted to know, could you explain a bit more how they work? So do they stop the migraine, or do they sort of block it?
That's a good question. I mean, what they do is that they're vasoconstrictors, and we think that what's happening at a cellular level is that blood vessels are becoming dilated, and this is somehow ramping up the pain system in the brain. And if you stop that, then the pain goes down. Basically, that's the simplest way of explaining it.
Lovely, thank you. And someone's asked, is it okay to take all the combination drugs as an acute treatment if you're pregnant or are trying to get pregnant?
Well, you could take, non-steroidal anti-inflammatory drugs should be avoided in pregnancy, so you wouldn't be able to have those. You could take the paracetamol and triptan and some of the antiemetics. You'd have to check with your GP which ones are safe in pregnancy.
Lovely, thank you. And someone said, what's the best way to manage aura?
Well, the problem with aura is you have to, if you're getting frequent attacks of migraine with aura, or with or without the headache, then you have to start a preventative. As I said, there are no acute medications for aura. So if you're having, awful zigzags in your visual field, there is nothing that you can have there and then which will stop those visual symptoms, and that can be really frustrating.
Lovely. And a bit more information on triptans. So just a bit more about the maximum amount that you can be taken in terms of treating an attack, but also during sort of a month.
Yeah. So in terms of how much you're allowed to have, as I said, they come in 2 doses. So for example, sumatriptan comes in 50 and 100 milligrams. If you have the 50 milligram dose, then if things aren't improving, then you can have another 50 milligrams, but then you can't have any more within that 24 hours. So you can't go beyond the maximum dose in 24 hours. Okay. In terms of how often you take them, again, if you're taking them regularly, more than 10 days in a given month, then you're likely to run into problems in the longer term. When I mean problems, your headaches are going to be more difficult to treat, and you may develop, paradoxically, you may develop more headaches.
Lovely, thank you. And should you take them during the aura stage?
No, there's no evidence at all that taking triptans during the aura phase makes a jot of difference.
Lovely, thank you. And someone's asked, with the kind of doses for the non-steroidals, would it have an impact on kidney function? And
definitely. So if you're taking them, if you're diabetic and you're on other drugs which are affecting your kidneys, you'd have to be very, very careful about that. And you can, as well as causing kidney problems, they can also cause gastrointestinal problems. And there's more evidence that taking non-steroidals long term can potentially cause heart problems as well. So, like everything in life, it's getting the balance right. If you do have gastrointestinal problems, then you should be on another drug to sort of lower the acid in your stomach. And this is when I get a bad migraine. This is what I do. I mean, I have a couple of paracetamol, a couple of ibuprofen, and I knock it back with a double espresso, and that works for me. And if you have problems swallowing tablets, which some people do have, then I would suggest taking them with some yogurt or some honey or some jam or something.
Lovely. And what would you suggest around acute treatment for people that are in their 60s?
Well, lots of patients in their 60s use triptans, providing you don't have any significant cardiovascular disease, then they're safe.
Lovely, thank you. And someone's saying that they've been on amitriptyline for a while, but they've not had any positive effect, so they're continuing to take triptans for their migraine. Is that a safe combination, and is there a better option?
Well, if the amitriptyline's not working, then you should certainly get the GP to switch you over to something else. Generally speaking, if you've been on a particular drug for at least 3 months, and you look back and you're thinking, well, my headaches haven't really changed at all, then that'd be a time to move to the next drug. In fact, with the oral preventatives, we say that if things haven't improved by at least 30%, then the drug is probably not working. The reason 30% is such a magical number in migraine is because there's a very strong placebo effect with migraine medication. And if you gave 100 people Smarties and told them that it was the latest, best, most expensive migraine preventative, then probably 30% of people would improve, and the placebo effect is very strong.
Lovely, thank you. And are there any long-term safety impacts from taking triptans for over years?
No, but the only problem is, many of us will develop ischemic heart disease or hypertension or have strokes later on in life, and as soon as that happens, the GP will, a big light will flash on the GP's screen, and you'll have to stop the medication. And if you become very dependent on that drug, then you can go off a cliff edge in terms of your headaches.
Lovely. And someone's asking, do the other formulations of triptans, such as the nasal spray, cause rebound and medication overuse as well?
Yes, unfortunately, they all do. They all do, which is a real problem.
Lovely. And we're having lots and lots of questions about CGRPs, as I'm sure you can appreciate. So someone is asking what the best route to getting a CGRP prescribed is at the moment.
This is a contentious issue, and I know this because I've worked in different hospitals, and the problem with the CGRPs is that the hospital needs the infrastructure to be able to prescribe them. And what do I mean by that? It's not just a case of seeing someone in clinic and then prescribing the drug. That you have to be followed up every 3 to 6 months after being prescribed. And if there's no capacity to do that, then some hospitals or trusts are reluctant to even start the medication in the first place. What you need to do is, if you've failed on at least 3 preventatives and you're really struggling, then you need to get your GP to prescribe you to, you need to get your GP to refer you to preferably a headache centre. Okay, so there are various headache centres or headache clinics around the UK, and this is where you're most likely to be able to get the CGRPs. Unfortunately, the GPs aren't able to prescribe them yet, which seems, if you think about it, seems a bit crazy, because many people will end up on CGRPs, especially now that they've been licensed for episodic migraine. And it may be the case that later on we'll realise that if they're prescribed earlier, then actually there is an economic saving, but I think it's too early to say yet.
Lovely. And if you try one type of CGRP, can you then try another one if that doesn't work?
Again, there is guidance from NICE that if one doesn't work, then you shouldn't really be switching to another. However, I have had patients that have been non-NHS patients where we have switched them and there has been some benefit, but the guidance at present is that if one doesn't work, you shouldn't really be switching to another with some of them. But again, it's the guidance is always open to interpretation, because if you have the one particular CGRP and you don't tolerate it, then that's different to it not working. So you probably could be tried on a different one.
Lovely, thank you. And some questions around the side effects. So someone's saying that hair loss is reported as a side effect, but they want to know if there's real world evidence of it as a side effect, specifically of Ajovy. And if so, do you know what the percentage of patients affected by this is?
I think with all these new drugs, if you give them to hundreds of thousands of people, then people will get a whole host of different side effects. And as an individual, you have to weigh up the pros and cons of being on the drug. If you have disabling migraines, which are rendering you bedbound, then you may feel that actually having some hair loss outweighs that. Is better than being bedbound. But equally, if you're having infrequent migraines, four headaches a month, and you're on a drug and it's causing hair loss, then the balance tips in the other direction. So you have to use common sense. But if you look at the BNF and you look at the side effects for paracetamol, there are lots and lots of side effects, because it's a commonly used drug, and you have to weigh up the benefits of all these different side effects, and realize that in drugs which are taken by hundreds of thousands of people, and in America there are literally hundreds of thousands of people on these drugs, and therefore lots of different side effects will be reported. But generally speaking, and everything else being equal, they're much better tolerated than the oral preventatives.
Lovely, thank you. And someone said that their neurologist told them that Emgality had a profound impact on the immune system and bone marrow, and that they couldn't recommend it. Can you comment on that?
I haven't heard of that.
Thank you. And any recommendations for treatment of migraine in children in terms of acute and preventive options?
Well, children and adolescents, it's difficult. Lifestyle is very, very important, especially for adolescents. So, I see a fair few 16-year-olds in my clinic, and their lifestyles are very different nowadays. There's much more screen time, and sleep hygiene is super important. you know, teenagers like going to bed late, they like lying in at the weekend, and these are things which we know aren't great for migraine. And there's a recent New England Journal of Medicine paper which actually looked at the different migraine preventatives head to head. These are the tablets, and actually there's no real evidence that migraine preventatives are useful in children and adolescents. It's much more to do with lifestyle. But that said, you can have a 16-year-old who looks older and probably physiologically is older, and therefore you know, may benefit from a migraine preventative. So again, as a physician, you have to use your common sense.
Lovely. And someone's asking, they were on amitriptyline for a while and it was working, but their headaches are getting worse again. Is it worth trying amitriptyline again and increasing to a higher dose, or would it be better to try something else?
You've got two options. Yes, of course, you could increase the dose, see how you get on, or you could be switched to something else. I mean, one of the frustrating thing about migraine preventatives is that many people will say that, yes, you know, they started on drug X and drug X worked really well for a few months, and then it just, for whatever reason, it stopped working. I hear this story all the time, and it's super frustrating.
Lovely, thank you. And someone said that their migraines are really bad and their sleep is the only thing that helps. But if you're saying not to nap when you have a migraine, what can they do instead? They try to stay awake all day, but it's too much sometimes.
That's a difficult one. I mean, the reason that sleep is so useful with migraine is because migraine is a condition where your brain is programmed to react to sensory overload. And therefore sleep is the best way to remove all sensory overload, and therefore, you know, it's a very effective way of getting rid of migraines. But if you're napping during the day, then in the longer term you're probably not going to get rid of the migraines.
Lovely, thank you. And any recommendations for treatment of vestibular migraine?
So vestibular migraine, that's a bit of a monster because it can make you feel very odd. You feel as though, some people feel as though they're continuously on a boat or just got off a boat, and it can be very, very disruptive. Generally speaking, and the two drugs that I go for with vestibular migraine, one is called cinnarizine and another one is called lamotrigine. Lamotrigine is an anti-epileptic drug, and often patients benefit from these. Another one that the ENT doctors like to use is beta histine. That can be useful as well in some patients. And if those don't work, then you just use the normal migraine preventatives.
Lovely, thank you. And in terms of sort of migraine attacks that occur with menstrual cycle, is there anything that can be done with hormones to help, particularly around the perimenopause and menopause stage?
Yes, so menstrual migraine is a whole different talk, but generally speaking, providing there's no contraindications, then estrogen replacement, either as a gel or pessary or patch, can be very useful. And there's no providing there's no contraindications, then HRT can be useful as well, especially in women that are perimenopausal. Some GPs get a bit twitchy about HRT and migraine, because if you have migraine with aura, then estrogen is high doses of estrogen are contraindicated because there's a theoretical risk of stroke. But don't forget, with HRT, you are replacing a hormone that's gone down in levels. So you're not giving any extra, you're just replacing something that's already low. In terms of menstrual migraine, I recommend estrogen patches, which you can apply 3 days before the onset of menstruation, and then you cut them in half every couple of days, and then take the final bit off after 6 days. So you taper the dose, and that can be very, very useful. And with menstrual migraine, if you take non-steroidal anti-inflammatory drugs and long-acting triptans like frovatriptan on a daily basis for 3 days before the onset of menstruation, and for a further 3 to 6 days, that can be very useful as well.
Lovely. And some questions around being on more than one preventive at a time and whether that's okay.
That's an interesting question. I mean, historically, we tried to just stick to one preventative, and this differs very much from how we treat patients with epilepsy who are often on more than one anti-epileptic drug. But for migraine, we tend to stick just to one preventative. But in some situations, you can kill two birds with one stone. So, for example, if someone's hypertensive, you may want to put them onto candesartan, which is a blood pressure tablet, and then you could keep them on that tablet, and then you could add something else like amitriptyline. So there are situations where you could use more than one migraine preventative. And many patients that are receiving Botox or indeed the monoclonal antibodies, they're already on oral preventatives anyway. I mean, in the longer term, you want to try and get them off them, but often patients take them in combination.
Lovely. And a few questions around Botox, particularly around the long-term safety effect of it.
So, I mean, historically, Botox, as everyone knows, is used to get rid of wrinkles and get rid of crow's feet. And it's been used for at least since the 80s to do that. And what happened was people were reporting back to their aesthetic doctors that they're getting less migraines. And then, of course, the drug company got wind of this, and they did a big trial and showed that Botox was very useful for the treatment of chronic migraine. Longer term, the only thing that it can do really is you can get some thinning of the muscle in your forehead and neck potentially, and that's because you're paralyzing these muscles. And everyone's heard the phrase, if you don't use it, you lose it. And if you're not using the muscle and you can't do that, then it will atrophy over time and become thinner. But again, whether or not that's a problem, I don't know. But certainly in my practice, I've taken over the care of patients that have been on migraine for 10 years, and I've been treating them for 7 years. So, and they haven't run into any problems at all. The problem with Botox really is because it's such an effective drug. The problem is getting off it, and it's a pain to come to the hospital every 3 months to have the injections. But when it really works, people just are very reluctant to come off it.
Lovely. And a few questions around people that have tried lots of different preventive treatments and none of them have worked. Is there a likelihood they're resistant, or should they keep going with different treatment options?
You've got to just keep on moving up the ladder. So look at your lifestyle very carefully. If you've gone for all the oral preventatives, then you would move on to either Botox, nerve blocks, or the antibodies. If you have any neck-related problems, then I find in my practice that nerve blocks are very useful. So the greater occipital nerve blocks are very useful. But unfortunately, you have to just keep on going through up the ladder, as it were. Looking back at my own practice, I've treated thousands of patients with migraine and headache over the years, and I've probably had less than 10 where it's been completely intractable. So we all, we can always do something. Basically, that's the general rule.
Lovely. And a couple of questions around how sort of when you've tried a medication for long enough and it's time to move on to the next one. Is there a time period you should be looking at?
Well, I think it's important to keep a diary. So just on your calendar, just mark down the headache days, and then top them up at the end of every month, and then see over time whether or not that particular drug's made any difference. I mean, it's difficult if you have daily headache. Then it can be a bit pointless doing a headache diary. But what I do in that case is I say to people, look at your life in a different way, and are you doing things on this particular drug, for example, going out or socializing or going to work, even if you're getting headaches every day, that you weren't doing when you weren't on the drug. So you have to think of it in different ways sometimes as well.
Lovely. And any recommendation for the best way to manage medication overuse headache?
With medication overuse headache, there's two sides to that really. If you're on opiates, then you need to come off them slowly, because otherwise you sort of have a train spotting situation where you will become very unwell basically if you come off opiates and do a cold turkey. If you're on triptans, non-steroidal anti-inflammatory drugs, or paracetamol, it's perfectly safe to just stop them there and then. Expect to feel completely miserable for at least 2 weeks. You have to tell your nearest and dearest that you're going to be cranky and very, unwell with headaches. You need to let your boss know at work that you're probably not going to be in. So it's best to time it around a holiday or something. But if you get to the 6-week stage and you've completely come off all your medication, then there's a good chance that things will improve. And when people do this, I always tell people, use your common sense. If in that 6-week period, there's a wedding or something really important, then of course you take your painkillers for that day, but just don't get into the habit of doing it. But in the longer term, I mean, there is some evidence that being on Botox and the new antibodies can facilitate you getting off painkillers if you are dependent on them.
Lovely. And there's been a couple of comments around opticians testing for the precision tinted lenses that you discussed earlier. Can anyone do that, or is it a specialist optician?
You need to go to a specialist optician. Basically, if you Google it, there's a machine called an intuitive colorimeter, and essentially you look into a box, and there's some writing in the box, and you twiddle various knobs on the side of the box, and it changes the light, and it essentially works out which tinted lenses you need. But certainly I wouldn't recommend buying them off the shelf or getting them off Amazon, because it's a very specific thing to what colours you get visual strain with. So you need to find an optician who essentially is happy to do the test on you. If you ever get given a particular coloured shaded lenses without without them testing you, then I would always think that's probably not the best thing to do.
Lovely, thank you, Ben. I'm just aware of the time, so I think that's probably all we have time for in terms of questions. Thank you so much, Ben. That's been really informative.
Thank you very much for inviting me, and for those of you that use Twitter, get tweeting. Lovely. And I do have a quick poll to share before everyone runs away, so I'm just going to launch that now, and we will be sharing a recording from the session next week. So if you can complete the poll, thank you all very much for coming. We really appreciate it, and I hope that you found it useful, and thank you again, Ben. It was really useful and really enjoyable. Thank you very much. Thank you for inviting me.
Thank you, Ben. That was really useful. Thank you.
Thank you very much. Thank you.
You're welcome.
Thank you.
Thanks.
Thank you.
Really useful.
Thank you.
Very much. Thank you very much.
Thank you very much.
Thank you. Take care.
Thanks, everyone. Bye-bye.
Bye.
Thank you.
Very helpful. Thank you.
Thanks a lot. Brilliant.